So good day, friends. This is Dr. Bob Hamilton, and you have tuned in today to the Hamilton Review, where kids and culture collide. And there's a lot of collision going on out there right now, friends, if you haven't noticed. So we have someone on the show who's going to talk about that. But before we get to my introduction of our guest today, I'd like to say one thing. First of all, thank you for tuning into this podcast. It means so much to me. Makes me happy because I do a lot of work to get the people here and to get these messages out. But I also know that all of you out there are busy moms and dads. You're chasing your kids around, going to sporting events, all the things that moms and dads do, and it means a lot when you tune in. So thank you for doing that. If you like what you hear, I hope you do. Pass it on to your friends and your family. The reason is because the people that come on my show on a weekly basis are special people. They're doers, they're movers, they're activists, and they need to be heard. And today is no exception. It's a great honor to welcome to the Hamilton Review today, Lauren Muhlheim. Dr. Muhlheim.
Thanks for having me.
You are welcome. So it's a pleasure to have you here. So let me introduce her and tell you who Dr. Muhlheim is. Dr. Lauren Muhlheim is a clinical psychologist and eating disorders specialist who conducts workshops and seminars for parents, treatment professionals, graduate students in psychology, and psychiatric residents. So she is out there teaching on a routine basis. She has written a beautiful book, which is entitled When Your Teen Has an Eating Disorder. The subtitle is Practical Strategies to Help Your Teen Recover from Anorexia, Bulimia, and Binge Eating. Okay, so this is an important book. And so Dr. Muhlheim, welcome to the Hamilton Review.
Thank you so much.
So I like to begin my podcast with having my guests talk about themselves. And I'm talking about going back into your youth and where you grew up, a little bit about your background. And really, I'm very interested in knowing what were the factors, what were the things that actually got you doing what you're doing today, and why you ended up with a PhD in education. PhD in clinical psychology. Excuse me.
ID.
I'm sorry.
PSYD.
PSYD. And why you're doing what you're doing. So I'm going to turn the microphone over to you and let you take it from there.
Okay, sure. So I grew up in White Plains, New York as an only child and an only grandchild on both sides, which was, I think, interesting because I was surrounded by adults my whole life and had very limited interaction with kids. I mean, school, but I always felt like I was surrounded by adults. And
I hope you felt like you were pretty special because you were getting, if you're the only grandchild,
yes,
an only child, you got a lot of adoration.
I did get a lot of adoration, but also a lot of pressure. So it was a mixed bag. But I, had a lot of opportunities, and I'm grateful for that. My father was a real estate attorney specializing in co-ops and condos, specifically in New York City. And my mom was a speech pathologist. And, I think I had very early messaging from my mom not to become an attorney because she saw the female attorneys at my father's office have to choose between like partner track or parent track. And I had very strong messaging not to do that. So I did not follow. I obediently didn't follow, to law school. And I went to college, and I was taking linear algebra and multivariable calculus. I was kind of on this like pre-engineering track at Princeton, and I had a French math professor who was almost incomprehensible, and there were no numbers left in the math, and I was very overwhelmed and ended up dropping out of math. And I think other than like my language requirement class, the surviving class was Psychology 101. So I think that played a role. But I think also I, had always been someone who people like to confide in, and I was a good listener. So I think that helped set me on my way.
Yeah, those events in your youth when you when you realize that the calculus is over your head. By the way, I kind of had that same phenomenon happen to me. Definitely in my fourth and fifth quarters of calculus. Why I took them was not required, but I think it was just masochistic actually. But you're right. Toward when you get into that level, you really friends. I don't know if you've taken these classes. The numbers go away. I mean, I happen to like numbers. I like to see,
Me too.
I'm pretty good with numbers, but when I got to this theory, I remember the one that knocked me out was this infinite dimensions. And I could never understand that. I still don't. I say it today and I go, I can understand 3 dimensions. I can understand if you say time is a dimension. Okay, I can understand 4 dimensions. But beyond that, I can't quite fathom infinite dimensions. And the professor would talk about this stuff like it was, yeah, they're infinite, like this was a reality. I just could never visualize that reality. Anyway, so you
Same trouble.
Yeah, exactly. So we hit the same wall. So you ended up you took a psychology class, and what happened?
So yeah, then I fell in love with psychology and just kind of knew that that was what I wanted to do. And I was one of the few people that went straight from undergrad to a doctoral program. I think I just, because Princeton was so theoretical, there were no like clinical research labs. So it never occurred to me to like go do research in someone's lab, which is what I might have done in retrospect. But I applied straight to grad school, went to Rutgers, and there I met Terry Wilson, who was running a bulimia research lab. And I had a friend who was a year ahead of me who had gotten to work in his lab and was raving about how great it was. And so I kind of pushed my way in. And Terry Wilson was one of the greats in the eating disorder field. And he was not easy to to please at first. So I worked really hard to get to work there. And then I fell in love with basically CBT for bulimia, which was my introduction to eating disorders. So that's how I got into it.
Yeah, and then you never left it. This has been something that
No, I did leave it.
Oh, you did leave.
I
Okay.
did.
Okay.
Yeah.
So tell
Yeah.
us about
So
that.
then I went to I did my internship at the VA in Northern California, and I did a postdoc at Kaiser in the 90s, and then moved to Los Angeles and had to find a job, and there were not a lot of eating disorder treatment centers back then. So I ended up at the Help Group back then, and then after a year at the Help Group, I went to LA County Jail, where I worked in the women's forensic program for 10 years, working with the severely mentally ill who were incarcerated. And then my husband got assigned to China for his job, and I followed him to Shanghai. And when I got there, well, I had started a brief private practice in the years before because I really missed doing eating disorder work. But then we picked up and went to China. And when I showed up at China and said I had eating disorder experience, I was literally handed cases of expat teens with eating disorders. And that's how I got trained in family-based treatment, because I realized the CBT I knew for adults wasn't really going to work for teens.
Yeah.
And the alternative there was to send teens back home to the US or Australia. So from there, I flew to Stanford and did a 2-day training in family-based treatment. And that's what kind of got me hooked on family-based treatment.
Yeah. When you say CBT, did you say, or CBD?
Yeah.
Okay. Can you?
It's cognitive behavioral therapy.
Okay. Sorry.
Which is a common treatment. It's evidence-based. It looks at what's maintaining a problem in the present day. So looking at the interaction of thoughts, behaviors, and feelings, and how they're maintaining certain problematic behaviors.
Okay. Okay. So I wasn't exactly sure what those initials meant, but okay. Cognitive behavioral therapy, and they use that a lot I think in autism and other aspects, right? Is that correct?
Well, they use it a lot. It's for treatment of children with anxiety, depression. Autism sometimes uses some different things.
Okay. All right. So, but it is a common. But you're now doing more of a parental treatment focus. So tell us about that, because this is very, very critical in terms of what you do on a day-by-day basis.
Yeah, so family-based treatment is a treatment that originated at the Maudsley Hospital in London, like in the 90s, and then it was brought to Stanford University, where it was manualized by two researchers, Jim Locke and Daniel Lagrange. And it's an evidence-based treatment. It's currently the leading treatment that we have for teens with anorexia and bulimia. And it represented a big break from past treatments where parents were often shut out of treatment and blamed for their child's eating disorder. And in family-based treatment, the parents are recognized as being assets to their child's recovery. And so it's really a parent empowered treatment where the parents are part of the treatment team and work to help their child recover from an eating disorder.
Yeah. I want to be. Well, you brought up something, and you've mentioned anorexia and bulimia. One of the things that I have parents who come into me and they quietly confide to me that they're not sure if their children really do have an eating disorder. What are some of the warning signs that you see in young people when they are beginning to maybe tend toward one of these issues?
Yeah, that's a really important question because I think eating disorders can look really different in children than they do in adults. And many parents and even many doctors may miss some of the early warning signs. And then by the time you really recognize it, it's gotten pretty significant. So it's really normal, and as you probably know, for kids to be growing along a certain trajectory for height and weight, and the height and weight may not match, but often kids are at a pretty steady trajectory for themselves, which, and just, a word about bodies are diverse, right? Not everyone is at the 50th percentile. So, someone who's always grown at the 60th percentile, that may be normal for them. So children, some of the early warning signs may be failure to gain weight. And remember that children, a lot of parents will say, my child didn't lose any weight. And it's like, well, but your child should have gained weight during this past year. So sometimes failure to gain weight is an early warning sign. Sometimes failure to grow, because when someone is really undernourished, they can fall off their height curve too, although that's usually a little later.
That's right. No, that's a very. I mean, if you're not getting good nutrition, you definitely do fall off the height curve. Although that is usually the weight is the one that falls off first, for sure.
Yeah. Yeah, and kids are not going to like express a lot of the things that adults express. They're not going to say like, "Oh, I think I'm too fat and, I'm trying to diet," right? So I think that makes it harder for parents to discern, but you may see behaviors like, rejection of previously enjoyed foods, and particularly, if they're the more nutrient dense foods, so children not eating, complaining of stomach aches. They may complain of a lot of physical symptoms. And, a kind of surprising behavior is often like excessive activity, which can sometimes look like ADHD, but it appears to be a symptom of starvation that we see in adults, right, with anorexia who over-exercise. But children don't explain it as like, oh, I'm trying to run, on the treadmill, but it appears to be like a behavioral symptom where they're just kind of running around, they won't sit still. And again, it's it's a disturbing and, seems backwards symptom, right? Because someone who's not eating enough should be exhausted. But we think that, there's a genetic almost glitch that happens in people who have the ability to develop anorexia, where they actually, have this urge to exercise. And there's activity-based anorexia in rats where they can replicate it. They can starve rats, and certain rats will they basically they reduce the food, they give them unlimited access to the wheel, and the rats will stop eating even during when the food is presented, like during the brief intervals, and just keep running, and they'll run themselves to death if they're not rescued. So that's a very unusual kind of symptom.
Yeah, interesting. How much is the behaviors associated with the cohort these kids are in? For example, gymnasts, ballet in particular, other dancers, other activities tend toward a body type. How much of that, when you're in that kind of a cohort of other boys or girls, really, how much does that affect the whole situation?
I mean, it can definitely be a factor, right? Those sports where a certain body aesthetic is, idolized or, encouraged. But I'd say even like before that, there's this, the amount of energy expended for people doing those sports. And we think that anorexia in people with the right genetics, right? Because there's a large part of eating disorders that have a genetic link. They think about 50 to 80% of the is due to genetics in the development of anorexia. 80% of 50 to 80% of the risk. But it appears that certain people have the genetics to develop it, and others don't. And what seems to trigger it in those who have the ability to develop it is what they call a negative energy balance, meaning, someone is not getting enough energy for their needs, and their brain almost becomes stuck and then fixated. And then we get brain changes that maintain the disorder. So, the most common form we see of that is a diet, right? A deliberate diet. Someone goes on a diet and they have a negative energy balance. But we also see unintentional causes of the negative energy balance, which could be these kids who are training really hard for their sport, and maybe, they're just not eating enough, or their appetite doesn't keep up, or no coach is, emphasizing the importance of fueling, or they go through like a really, sudden growth spurt and their appetite doesn't keep up. So all of those things can put someone at risk.
The other thing is body perception. I've seen, I had one gal in particular who was very, very severely anorexic, and I would have conversations with her, and I would say, "Listen, she would say, I'm so fat." I go, "Well, you're actually not fat." And she would pull skin. She would grab her tummy and she would get some skin, is what it was. There was zero fat there. And she said, "Look how fat I am." And I could never convince her that she wasn't fat. And sadly, I will tell you that she actually passed later on after she left my care. She got into a very, very bad place, and she ended up passing as a result of her anorexia indirectly. And it wasn't direct, but it was definitely indirectly.
Yeah.
So this idea of body image, so they also be there, these people who fall into this are really looking at their body in the wrong way. I mean, a lot of the kids that I've seen are actually beautiful. They're not fat at all, but they perceive that, and it's almost impossible, in my mind, to change that perception.
Yeah, and that usually comes later, right? That real distortion, right? So if we're talking about, the progression, that's usually after there's some brain changes. And we in the field now call that anosognosia, which is a term that's also been used to describe people with brain injuries who are not aware of their deficit. And it then also started to be used for people with schizophrenia and bipolar disorder. And now it's been applied to people with anorexia. And it makes sense because when they do brain scans or MRIs of people with anorexia, there's actually less gray matter in the brain. So it would make sense that their brain could be affected, and they really are not aware of their illness. And that's one of the really tough things about treating them, right? Is if a child, is so distorted, you can't convince them to eat, which is again, like one of the reasons why family-based treatment is such a good treatment, because the child doesn't have to believe they're ill. They don't have to agree to treatment. The parents, do the heavy lifting. But I just want to come back to, the other symptoms, because I want
Yeah,
to be
important.
sure we cover those. Um, so children, are often not going to voice these, like, I'm concerned about my weight early on, right? It's going to typically be more subtle. You'll look for behaviors, you'll look for dropped foods, you'll look for maybe some excessive exercise. A very unusual but common symptom is a very strong interest in cooking and baking, but then not eating what you cook or bake. And a lot of parents miss that, and they think it's like a good thing, because like suddenly their child is interested in food and maybe even nutrition, and which seems like a good thing, but oftentimes it's an early sign of an eating disorder.
Interesting. You would think the very opposite, wouldn't you? But it's
Yep.
fascinating. So you mentioned it a couple of times, and I want to get into this, the idea of family-based treatment. What is it, first of all, and how, who provides this? Is the mom and dad, or are other relatives, grandparents, and siblings? Who's involved with this, what you call FBT?
Yes. So family-based treatment is typically delivered by a therapist. It could also be a dietitian leading the parents, and it's primarily a team approach where, and there's also always a medical doctor, right? So we need a medical doctor, right? Because we're seeing kids who could otherwise be in residential treatment. So we want to make sure that they're medically stable and not at risk for refeeding syndrome. And so it's usually a team approach. And so like sometimes I'll work with, the patient's existing pediatrician. Sometimes there's a need to bring in a specialist, eating disorder doctor. And sometimes there's a dietitian as well. And then the parents are considered part of the treatment team. And the parents are really, I think of it as like running a residential treatment center in your home for your one child.
Hmm.
So the parents are kind of like the treatment center staff. And I tell parents, that means you are preparing, or you're planning, preparing, serving, and supervising all the meals for your one child in recovery. And it's really through these family meals that parents nourish their starving child back to health.
So I think about this, and I think about, there are dysfunctional families. There are mothers and fathers who do not have the capacity to perform the function. Okay, so they're cooking the meals, or they're eating together. What is that? What does that meal look like when the kid says, "I don't want to eat"? How do you? Because these children are not afraid to talk back to their parents. You
Right.
know that. So what does that look like?
Yeah, well, so that's why, it's helpful to have a therapist and a team behind you, because parents do need a lot of support. I don't mean to imply that it's easy. And, like I said, the context of anorexia and other eating disorders was that parents were typically blamed. So, with this new approach, we give parents the benefit of the doubt. That doesn't mean that it's for every family, but we give parents the opportunity to try in most situations. And it does take a lot of work. It's a big commitment. I've had, parents who are both doctors take 2 months off work to stay home and start, refeeding their child. So it really does take, parental superpowers to stay calm when your kid is refusing to eat. And it's terrifying. And not just like, kids being angry, but sometimes really escalated behaviors like, throwing food or running away or threatening to hurt themselves. So that's where I think a therapist is really helpful in terms of educating parents, giving parents tools, helping them to stay calm, and just kind of being persistent, and also setting up a structure so that the meals happen. Like, I like to remind parents that even teens who go to residential treatment, are usually not tube fed, right? So how does the staff there get them to eat? It's largely structure and expectation. So,
Yeah.
you come to the table, you eat your meal, you have a time to eat it. If you don't eat, there's a consequence. like in a treatment center, you wouldn't go to the next activity. If you're doing family-based treatment, then you don't go to school. For most of these kids, school is a reinforcer because they're getting out of the house and away from the parents.
Yeah.
So we try to use logical consequences, try to use, positive rewards when we can for meals completed. And, it's of course scary because the reason the teen is not eating is not because, they're trying to be difficult. It's because their brain is controlled by this eating disorder and they don't have control and they're terrified. And so we're giving parents skills to help parents stand up to the eating disorder on behalf of the teen who's really not able to make those steps on their own.
You mentioned that this is evidence-based and that is actually superior to a lot of other therapies. And I first of all, just as a comment, the fact that it's family-based, I love that. I love families. I think that families, I was saying this before to you, Dr. Muhlheim, that, who are the people in the lives of children who are totally invested in their children? Well, the parents, the mom and dad from day one have been caring for these children, loving them, and they are, except for rare situations, they are heavily, heavily invested in the success for for their children's success in life. And so I'm glad that you have mentioned to me in our pre-call that sometimes parents have been wrongly excluded from therapy, and I think that speak to that in terms of historically the therapies have been used.
Yeah, so historically, like way back in the 1800s, parents were blamed for causing eating disorders, and this really persisted through Hilda Brooke in the 1970s, who wrote a psychodynamic popular book about anorexia. And you probably are aware of, the schizophrenogenic mothers were blamed for their kids' schizophrenia and also autism. And, I think now we understand that there are like genetic bases for those disorders. And I think the same applies to eating disorders. But I still find that when I tell people what I do, people are often quick to say, isn't it the parent's fault? And so, this is really a pretty different treatment. And I think, it's like you said, parents love their children more than anything. No parent is perfect. But we, in most cases, we need to give parents the benefit of the doubt and let them try to do this. It's, ripping a kid away and putting them in residential or PHP is hard on the family. It's hard on the kid. Sometimes, they're exposed to other things in treatment centers. And so there's, and I always say, like, you're nourishing them at home with the food that they've grown up on. And there's something like really powerful and beautiful in that, I think.
No, and what you just said about exposed to other things in these treatment centers, there's no question that these treatment centers are not these pristine little perfectly functioning units either. There are some things that happen in these places where their parents are not there that you don't even want to know about. Drug use and all sorts of different things go on under in the dark at night, I guess you would say. So, I'm curious. We talk about this diet culture. Maybe in the U.S. it's a big deal. I mean, certainly there is an issue. This is, this to be true, that obesity is something that is becoming more and more of an issue in America. And I see it in my practice. I see kids getting overweight way too young. But this idea of the diet culture, which I think is very, very prevalent in Los Angeles and the west side of the city and really throughout the Western culture in certain areas. Can you speak to that and how that feeds into bulimia and anorexia?
Yeah. And, we are existing in a time where there's a very strong, I think, concern about body size. And, way back in early history, larger bodies were actually celebrated and seen as, healthy and prosperous. And body size has now become medicalized, right? Which means it's a problem to solve, and that there's a $70 billion like diet industry that's focused on solving this. And the research shows that diets don't work. Like 95% of diets fail and people gain the weight back plus more. So what's, I don't know. I'm really anti-diet, and because I see, all the wreckage in terms of the people who come to me with failed diets and eating disorders. So like if there's a gateway behavior to an eating disorder, it's dieting.
Yeah.
So I think, I don't know, I know you and I probably have different perspectives, but I think it's really important to understand that bodies naturally come in different sizes, and really trying to kind of work towards, acceptance of all bodies. And if we can make the world a safe place for people in larger bodies, I think there would be a lot less eating disorders all around.
No, there's no question. And by the way, I see kids who have different bodies all day long. So it isn't like, there are some there are some kids who are just big people, and other kids are these puny little kids, and I spend my entire day telling the parents, listen, they're okay. They're fulfilling their genetic code is how I put it. Their potential. This is kind of goes back to their DNA and what their DNA is dictating to a large extent. But how much of this diet culture is being propagated and pushed by way of just the social media and the access we have to the internet and these beautiful bodies? By the way, some of these beautiful bodies are fine-tuned by AI. You know that.
Yeah. Yeah. Well, social media, I think, is just another thing that's out there adding to this culture, right? And teens who are on their phones a lot are definitely exposed to photoshopped bodies and feel this pressure. I have I'm working with a college student who recently, deleted Instagram and, saying they feel so much better, right? Just not being exposed to that. So, I think it's everywhere, and it's hard. I a while ago outside of my office, there was like a cool sculpt, huge billboard, like right outside the office. And it's like, okay, people are coming here to like learn how to stand up to diet culture and accept their bodies. And there's the cool sculpt ad, right? I mean, it's harder to recover in this context, right? Where everyone around you is dieting. And I think we have so much work to do as a society to work towards making it okay to be bigger. And from what I understand, and you're a doctor, I'm not, but I understand that a lot of the medical training is very focused on solving obesity. So I think that like informs the way our health system is organized.
Yeah, I mean, certainly part of that is because with people, these young kids in particular, they're carrying more weight than they should simply because their diet is really lousy, and they're loading up on things that truly are not healthy for them. But there is a range. There's a range of normalcy, and we need to accept that. So, how do parents foster healthy relationships between food and their children's body? How do parents do that?
Yeah. So I think, in terms of food, I think it's really helpful to model like an all foods fit perspective. And, that it's okay. I don't like really to delineate between like junk food and healthy food. I just like to, parents to kind of model that there are fun foods, and there are, foods that maybe are, a little more, have a little more nutrition, but they're all part of a healthy diet. And, restricting kids tends to backfire in terms of binge eating. And so, there's some good models for encouraging intuitive eating in kids. A book by Sumner Brooks and Amy Severson, I think it's called Raising Intuitive Eaters, is a really good one. And I think, parents can, and again, I don't think parents cause eating disorders. I don't know that parents can necessarily prevent an eating disorder, but there's some protective factors that parents can help with. So like I said, modeling all foods fit, and then also the way, that we're talking about bodies. I think, talking neutrally about people in larger bodies, and, not modeling, fear or disparaging of people in larger bodies can go a long way.
So true. So true. So there's a thing that an entity that you introduced me to, which I'm thank you for doing that, is called ARFID, and that means Avoidant Resistive Food Intake Disorder. Um, I did not know about this disorder, and so can you walk me and also our listeners through what ARFID actually is?
Yeah. So ARFID, or Avoidant Restrictive Food Intake Disorder, was only, became a diagnosis in 2013. So it's kind of the newest eating disorder around, and you're probably seeing it in your practice. So these are people who don't eat enough, and it's not because of weight or shape. So unlike anorexia or bulimia or binge eating, which are believed to be largely driven by concerns about weight and shape, ARFID is where people limit the amount or the variety that they eat, usually for one of three reasons. And these are the three subtypes of ARFID. So one is a sensory sensitivity type. And these are what you probably know as the selective picky eaters. These are people who tend to have about, 5 foods, and they don't expand beyond that. And it either affects them in terms of their health or socially.
Yeah,
So Go ahead.
I think that all 2-year-old kids have ARFID because
Yes.
they're all food fattest. They all get in number one food is, of course, mac and cheese. Of course that.
Yeah.
And that's all they want 24/7. And so, okay, but that obviously you were
But
not
they don't outgrow that. This subset, right? Like, that persists. And I have adults. I run an adult support group where, it's like mac and cheese, chicken nuggets.
That's right.
Um,
Yeah.
yeah.
Yeah,
So
that's another one. Yes. Okay,
pizza.
so
Yeah.
that's type 1 of ARFID. What's number 2?
Number two is a low interest type, and this describes people who may be born this way, also like the sensory sensitivity type, that may be genetic largely. The low interest type may be kind of like born with like a lower hunger drive. These are people who, just don't get a strong hunger signal. They don't find food that rewarding, and they get full very easily. Um, and those two often occur together. And then there's a third type that is called fear of aversive consequences. And this type usually has a later onset. It's often a more acute onset. And it describes people who become afraid of eating because they're afraid of something bad happening after eating. And the kind of the themes that they're afraid of are usually like choking, vomiting, or GI distress. So we see a lot of this with people with IBS,
Yeah.
have a lot of, ARFID overlap. I see a lot of people with a lot of kids and adults with vomiting phobias. Um, and, also I've had some like acute cases of choking phobia where a child, gets hospitalized and is afraid of eating altogether.
Yeah, I've had a couple of kids who've had really they are afraid of choking. What about kids who have texture? Like I have kids who do not one example, they won't eat a peach because of the peach fuzz. What do you think? Is that part of the ARFID thing as well?
It can be, part of the first type. But again, it depends. Like to be diagnosed with ARFID, it has to affect you either physically in terms of your health or socially. So I have seen some teen boys who were significantly, height suppressed, because, puberty delayed because their weight was so low because of ARFID. And or I see, teens where it's starting to affect them socially, because they can't go out with their friends. I also see a lot of parents who are beside themselves because their child will only eat, French fries from McDonald's, they'll only eat pizza from Domino's, and the parents are, the kid can't go on they can't go on vacation. They have to bring all the food. They can't go on a trip because it's really hard for them to eat, any variation. They're just very sensitive to.
Do you see these kind of, you see ARFID, you may not be able to answer this question internationally. Like when I think about areas of the world like Africa and South America where the nutrition may be more compromised in terms of there aren't grocery stores in every corner. Do you see this internationally?
It's definitely internationally. I was at the International Conference on Eating Disorders in March, and there was collaboration with researchers from the Netherlands and, um, you know, all different countries. And they said, what changed was like the preferred foods, right? So, like the foods that they start eating as a kid, like in the US, it's mac and cheese. In the Netherlands, it's like some kind of toast with butter and chocolate sprinkle. So yeah.
Yeah. Okay. And I have one more question for you. I'm watching our time here, friends. And so I do have a question, which is kind of maybe the opposite. Okay. And this is, what do you do when you think that your child is gaining too much weight?
The first thing I think is don't do much. Just try to like take a deep breath and think about where that's coming from, right? And um I know where that comes from, right? Because every parent has been indoctrinated in diet culture, and you want your child to be healthy, and you're told that, that's the scariest thing and something really bad. But I think, panicking and putting your child on a diet is going to backfire. So I would want to, talk to the pediatrician, really look at their growth records, really try to understand what's going on. I look at a lot of growth records, and to be honest, I see a lot of, and I've been trained, I've actually done some trainings on studying pediatric growth records and setting recovery rates with a doctor I've collaborated with a lot. And what I see is, and what she has taught me is a lot of kids grow out before they grow up, pre-pubertal. And like, over that years of, a lot of kids gain 50 to 80 pounds to propel to their adult height. So what I see is a lot of kids start to go through that, and then someone panics, whether it's a parent or some health professional, and they go on a diet, and then they develop anorexia. And then we have, very scary situation, as you alluded to, it's a very serious illness, and people do die of eating disorders. And then we have to get them back on track. And, if they had just been allowed to, hold on to that weight, they would have just grown up, and, it would have been
Right.
part of their, adult height and weight. And they really need that weight. That's the pattern that a lot of kids grow. So I would say mostly just like watch and wait and talk to your pediatrician, and do your own work around weight stigma, right? Like, why is it so scary? Why are we so afraid of it? And it's, because we're in a cultural context that makes you feel like you're a failure as a parent, like you're a bad parent. But some people are meant to be bigger than others.
Yeah. No, it's really true, Dr. Muhlheim, that there usually is not uncommon to see kids kind of plump up a little bit. And then I actually think that the body is getting ready to grow. So you need a little bit of energy to do that. And that extra weight is actually a little bit of a storehouse of food that is going to allow the body to like take off. And I saw that actually in my own family to a degree. And they turned out fine. They turned out to be fine adults. There's no issues, one way or the other with weight. So that's something that's very important to think about. And I think that's very, very good advice, just to watch and wait. And we did see, I will tell you, during the pandemic, there was a bump in everybody's the weight. I mean, that was so clear to me. And I think it's just because of the sedentary lives and the isolation and the boredom and the anxiety and all the other things that were kind of being thrown at us during those years. Thank God we're over that. But I'm sure you saw that as well.
Yeah, but I also saw the opposite, where like a huge number of teens were so anxious about that they all started exercising and developed anorexia.
I guess it goes both ways.
Yeah.
Okay. Well, Dr. Muhlheim, thank you for taking the time to come on the Hamilton Review today. Again, her book is called When Your Teen Has an Eating Disorder. You can get it on Amazon. I did. And it's an excellent book. It's kind of a how-to book, what you do and how to get involved. I love the idea of parents being involved. You're empowering parents, and this is a group of people that don't need a lot of motivation because they're already empowered. They're very concerned, but engaging them in the process of healing is so critical. So good job on that. Okay. How do people find you, Dr. Muhlheim?
Yeah, so I run a group practice. I have about 8 therapists working for me, and the group practice is called Eating Disorder Therapy LA. We treat eating disorders in people of all ages throughout California. We do telehealth, and I have an office in the Mid-Wilshire area. And we accept many insurances too.
Very good. So that's how you find her. And also when you find her book. It is excellent, and you can put it to work. So Dr. Muhlheim, thank you so much for taking the time to be on the Hamilton Review today.
Thank you so much for having me.
You've been a wonderful guest. And friends, until next time, thank you for tuning in. It means a lot to me. And until next time, be well. Bye-bye.
You have been listening to the Hamilton Review, where kids and culture collide. Thank you for allowing us to be a part of your day. Tune in again next week on Apple Podcast. Rate and comment and tell a friend.